And the Oscar goes to, thank you all for coming to our third annual HIV symposium. One of my goals at Eisenhower is to make people throughout the country aware of just exactly what we do here. Because really we have per capita one of the largest aging population of people with HIV. And I think that sets us in a very unique situation. So I'm very happy that some people that have come here, as far as Dr. Bellows from Dallas, Dr. Hassler from San Francisco, who else is here? I mean, people that we've known for years, from Stanford, from Phoenix, because I really want to turn this basically into a national symposium. And it starts by people seeing who we are and what we do. So I think importantly, it's important in order to understand where we are, to get a perspective of where we've been and where we want to go. And I've known some of you, not unfortunately, but it's unfortunate that it's been 40 years, right? And we're still fighting this fight. But we've made quite a large and important progress that we always should keep in mind. So, I was telling people how to advance this, and I don't know if I know how to advance this. So, left click. There we go. So I am a speaker for Gilead Sciences. So I don't know how many of you remember Vancouver in 1996, and we're there. All right, we were there, and I'll tell you why that's important. So the HIV epidemic started in the 1980s, as we all know, and there was a peak of death that sort of peaked in 1995, 1994, and we were unfortunately losing approximately 50,000, right, of our patients, of our brothers, of our partners, of our, just family members at such a brisk pace. I remember in my practice, we would actually probably lose 2 or 3 patients a week. And then, and median age, actually, after diagnosis of survival was 1 to 2 years at that time. So we had this rapid escalation, and then something miraculous happened in 1995, 96. At that time, if any of you remember in Vancouver at the retrovirus conference, David Ho stood up and said, we have a cure. And what he presented was the information of protease inhibitors and highly active antiretroviral therapy. And the deaths plummeted, immediately plummeted. They introduced HAART. We saw that there was sustained viral suppression and that it was possible. And AIDS fell approximately 60% within 2 years of that initiation. So anybody that says that we haven't gone far, we have. But what we haven't gone is far enough. And that's what we're going to be talking about a little bit today. Today, there are approximately 5,000 deaths of HIV-related causes per year in the United States. Not necessarily HIV, but some of the things we're going to be talking about today, HIV-related deaths. Life expectancy is near normal. Actually, for the first time, I think in the 2 years that I've been here, this week I had 2 new patients that became HIV positive that were newly diagnosed. One was 72, the other one was 55. Neither of them had been on PrEP. That should not happen at this day and age, right? But it still does. It still does. So we still have work to do. Anyway, so we looked up the life expectancy of people that are HIV positive. The life expectancy of someone who's HIV positive in the United States at this time, who goes on highly active antiretroviral therapy, is to live to 78 years. All right? Also considered chicken in Palm Springs, actually, 78. HIV is rarely the cause of death. It's all these secondary manifestations of HIV and aging that causes that. So we see people that die of infections of kidney disease, liver disease, non-AIDS related cancers, cardiovascular disease. And we're going to be touching upon most, if not all of these in today's lecture. So the aging HIV population, as people live longer, we're doing what we were supposed to do and what we meant to do. People are living longer, and the average age, actually the median age of people living with HIV is somewhere between 50 and 59, which actually in Palm Springs, we consider them fetuses, Come on, it's true. Anyway, but my point is we're living longer, And sometimes we forget when we see patients that are HIV positive that we are dealing with a 55, 60, 65-year-old person that has the same comorbidities as anyone of that age. All right, and maybe so. So we have to start considering and taking care of our patients as total people, not just people with HIV. And that's what we're here for. So the diseases of aging, as we know, cardiovascular disease, osteoporosis, especially with some of the medications that people are taking, neurocognitive syndromes, diabetes, metabolic syndrome, and we consider this something that's maybe not important, but frailty and polypharmacy. Sometimes we're our own worst enemies, right? And we provide our patients, for the sake of expediency, sometimes with too many medications. So we need to keep that also in mind. So our take-home message is that we've come very far. HIV has evolved from a fatal illness to a chronic disease that's very manageable. All right. The major challenge that we have now is the aging that we're seeing in our HIV patients. And that's what we're here for today. So modern HIV care should focus not just on prevention. There's no reason anybody should be HIV positive in the United States nowadays, even though we might be entering a new dark age, but that's something else. And the longevity of our patients is very important.